pleasure of announcing yet another presenter. It's like what I love to do. It's fantastic. So this next presenter is going to be discussing and going over the bridging of the gap, post-physical therapy strategies to improve return to sport success. And I've had the pleasure of knowing Claudia for quite a bit of time, you know, at The Rock and then now at MSOE. So it's just, we picked a great panel of presenters. The patients love you guys. They just can't say enough. You guys do great things. You really get the patients and athletes back to where they need to be, both psychologically and physically. So I'm super happy to be able to announce your presence here. And you're going to do a great job, I know it. And so Claudia Curtis did her Bachelor of Science Athletic Training at Carroll University. And she has a Master of Science in Kinesiology and Recreational Athletic Training emphasis at Illinois State University. And so she currently is at MSOE. So if you guys could help me warmly welcome Claudia to the stage to have a great presentation. Thank you.
I'm self-mic'd, so please let me know if you can hear me in the back. I'm not an AV person. Thank you, Dr. Edwards. Happy to be here and to speak on bridging the gap between physical therapy and what we do as athletic trainers, getting our athletes out there for hopefully new successes, greater successes than maybe previous to injury. I have no disclosures like everyone else. Looking at what we're going to talk about today, we're going to identify the current functional movement assessment tools that are available in the research to clinicians to evaluate movement dysfunction. From there, we're going to evaluate any research gaps we think are present, affecting using these tools, and how do we implement them in our endurance population, comparing what's in the research, how it's designed, and looking specifically at our target audience for today's talk. And then to finish things up, we'll develop our strategies that we need to employ to successfully transition these athletes from their post-injury status, or where they're still considering themselves injured, and take them back to just being an athlete again. And athletic training, first domain, prevention, prehab, we preach it probably every day at MSOE. So really looking at this as a takeoff point. Okay, you had this traumatic event, this long-term injury, and how do we take this and create it as a takeoff for maybe preventing that future return to our office, as much as we do like, as Dr. Edwards mentioned earlier, seeing our patients over and over. We much prefer to see them in the casual, hi, how are you, how are the children kind of way. So here is a list of tools based on the research for assessing movement. This is just a laundry list of different resources available. Certainly this is not an exhaustive list. This is a list that most repeatedly shows up in the research. I tried to order this list kind of in a logical progression of what you would utilize first, and then go through from there as your patient, your athlete progresses, what you would want to utilize to evaluate them and look for these movement dysfunctions to hope to prevent new injuries, fully address the current injury that you may be seeing them for, and really get to the root of the problem. My boss, Dave, is historically known for saying we don't put Band-Aids on injuries at MSOE. That is not our goal. We want to find the root of the problem. We want to make sure we fully address it, and then we want you to go out there and show us what you're made of. So that's one of the biggest things we're going to hopefully be able to unearth here, is where did this, this knee injury, did it really come from your knee, or as has it been mentioned already today? Let's look up that kinetic chain. So we're going to address not only where the injury is coming from, but potentially things that do not show up in your traditional testing. You've met all your range of motion goals. You do your manual muscle tests. They are 5 out of 5. You're doing isokinetic testing, and you're going, hey, you've got that 90% or greater limb symmetry. But what does that translate to when it comes to function? So that is really the goal of what we're doing here, looking at these different assessment tools. I will preface this with, I am not directly aligned with any of one of these tools. I am not FMS certified, or I'm not selling you these tools. I am literally showing you what is available, explaining their design, who they're appropriate for, their implementation, and then we all have great clinical decision-making skills. My goal is for you to understand these enough to decide what you want to employ in your practice, how you want to employ it, and when you think clinically it's most appropriate to employ it. So we'll start with the selective functional movement assessment. I am certain my PT colleagues in this room are the most familiar with this test. The biggest thing to note, the SFMA is designed for patients with pain. So they are looking for that pain on a more of a regional approach through movement. And you can see the movement patterns that are assessed. They kind of do a top-down approach from the head. And then they continue from there. Once they find the source of the pain, they look how the movement is affected. And then their goal is to restore that normal movement, obviously get rid of the source of the pain, improve stability, control, address any asymmetries you see with the movement, with the quality, the quantity, anything along those lines, and resolve the issue that is at hand. So this would be the first plan of attack when you have a patient that's complaining of symptoms and you've addressed a lot of these. This kind of easily integrates into your evaluation. You're looking at static posture, you're looking at dynamic posture, you're looking at range of motion, you're looking at how things interact. So this is a very easy tool to implement in different areas of your evaluation process as a clinician, and then test, retest. Moving along to the functional movement screen, I need to preface that this is not an assessment tool, it is a screen. The research does not validate using it as an injury assessment tool. It's designed for healthy population, so you keep that in mind when you integrate it into your practice. And you're looking at, as you can see from the pictures up there, almost all of these activities, with the exception of the shoulder mobility and the active straight leg raise, are full body movements. So we are taking that regional approach and making it a much more global approach with functional movements. Certainly some of these you can directly look at and compare, say, I'm a basketball player. I need to be able to squat, especially with my arms over my head. You can more directly apply it potentially to different scenarios. So it's this list of 7 exercises. Like I said, the population is to be pain-free, potentially, and looking at more normal range of motion has been established. You need to get through certain hurdles in order to get the full function out of the FMS. That doesn't mean there's no merit to doing these during an active injury state. You're just going to need to retest and know that modifications may need to be made. They're not going to score 3 things along those lines. Which brings me to the scoring process. 7 tests. Each test is out of a 3-point scale. You're looking for pain or compensation that would decrease those. Again, I am not an FMS screener. I'm not going to break down the tests at that point. What's incredibly important and is validated in research over and over again is that athletes that score 14 or lower are associated with an increased injury risk. And I will bring up study after study that continues to validate that and then continues to frighten you a little bit as a clinician regarding what you're seeing in some of these screens, what these healthy people are testing at. Moving along to the STAR excursion balance testing, and this could reasonably be put earlier, but it is a single limb test, and so I did include it at this point. I would assume every clinician in this room is familiar with the STAR, whether they call it the STAR or they just call it a single leg vector balance test or single leg stance with excursion. It shows all of the directions that are potentially involved. Most of the research on STAR balance has limited it to the anterior reach and then the posterior medial and the posterior lateral reach. They aren't necessarily seeing utility with the other directions. Certainly sports or activities of daily life or really anything occur in multiple planes of motions and at multiple angles. So they're not saying to not use the other positions for training techniques, but with regards to the research and injury evaluation, they will focus on those 3 movements specifically. So with your clinician evaluation, you're looking at both quantitative and qualitative results, or you have the ability to do so with the excursion reach. You can certainly quantify that, and you have a nice control potentially by comparing bilaterally. And you're really looking at a global approach here. Your most obvious things you're looking at, what is their foot and ankle doing? Do you see pes planus? Do you see pes cavus? What kind of compensations happen there? Is there increased knee valgus? Is there increased femoral internal rotation? What kind of neuromuscular control do they have? And you just can continue to work up the kinetic chain looking at it. It's appropriate for anybody that can single limb stance without an assisted device, without upper extremity assistance. And certainly they need to be able to single limb stance for 10 to 20 seconds as kind of a screening tool for progressing to the STAR excursion balance testing. But it is, if you have a training room and you have tape, you can certainly create it. It requires very little in order to complete the test in terms of financial needs. So we'll go directly into the Y-balance test. The most familiar one is the lower extremity Y-balance test. Like I said, the 3 directions are those that they're focusing on the research: the anterior, the posterior medial, and the posterior lateral. And they are directly looking for quantitative asymmetries. In the research, it shows that time and time again, if there's an asymmetry of greater than 4 centimeters in the anterior direction, that increases your risk for injury. They're a little more gray area. I've seen anywhere between 4 and 6 centimeters for the 2 posterior directions. But certainly asymmetry is what you are looking for here, and they have tried to quantify that. Is shown with equipment. Certainly the STAR balance test is doing it with tape as opposed to the fancy equipment. So that can be a potential barrier for certain settings, is that they do have this employed with a little bit of they have a process where you put a formula in, and I'm missing the fancy word at this point, but you would use their software to include some of your demographic information, your excursion information, your limb length algorithm. And that kind of all comes with the purchase of the apparatus itself. However, that's not to say that we cannot find ways to use it in our clinical settings without having the equipment available. It just modifies the test a little bit and probably limits our utility. One that I didn't really have a lot of information about prior to now is the use of it for upper extremity testing. The biggest thing that they have found, everyone thinks about, I'm so right hand dominant. If I couldn't brush my teeth with my right hand, it would be a hot mess. My makeup would be everywhere. I wouldn't go out in public. So you're going, if I'm that dominant, how does that show up on a test? Well, in the research with healthy controls, there is no effect of limb dominance. While they do see that if you are balancing on your non-dominant arm and excursioning with your dominant arm, you do see a little bit of an increase. It's not statistically significant, and it's very consistent across the board, consistent across gender, activity level, and that it does not affect the validity of finding asymmetries. So that asymmetry of greater than 4 centimeters is again associated with increased injury risk, and that would be what you would be looking for. One other upper extremity functional test is called the closed kinetic chain upper extremity stability test, or also known as the Davies test. Testing procedure is, as that gentleman is up top, underneath his 2 hands currently is the other piece of tape. They are placed about 36 inches apart, and you start in that straight push-up position at the top. It's a 15-second test, and it's as those CrossFitters love it, AMRAP, as many reps as possible in 15 seconds. There is no way to control asymmetries. The test literally looks at core and upper extremity endurance and speed, so that's one limitation of the test. So you would have to have a baseline, or you can retest. When you look at that, is this appropriate for your entire population? Potentially no. But how do we modify a plank and a push-up in our practice for those where a full push-up and a full plank is not appropriate? We go to knees, we increase the level of where their upper extremities are, tabletop, wall, and you just deload the body. So there's no reason, but there's no research out there as good clinicians, there's no reason why we can't take that same approach and measure progress. Because at this point, our patient is the retest. They're the one that you're looking at to compare progress, and you're certainly going to be able to see progress when they can do more reps in the amount of time, they can accept more load, and then you talk about qualitatively, what is their body positioning like? Can they maintain that strong plank position without any sort of biomechanical compensations? Reactive neuromuscular testing, which is a fancy way of saying plyometrics. This slide, I would be surprised if anybody in this room raised their hand and said, I've never seen that diagram before. Every ACL return to sport article in the literature, I cited one, but I could cite 15. Every ACL article that I used for this presentation, I can pull that from a Google search. That's going to pop up right away. This battery of 4 single leg hopping tests have become our bread and butter of what we use for return to sport, comparing asymmetries in strength, distance, completion time, and qualitative against your own uninjured control. Again, it's another tool that's very easy to use. You don't require a lot of equipment. There aren't a lot of limitations in terms of employment when all you need is a ruler and a stopwatch, which we all have on our cell phones now. We take this information and then we look at limb symmetry index via getting out our calculator and using some math. So this is, when we think return to sport testing, I would guess that by a show of hands, people would pick this one first. This would be your go-to. This would be what when you think return to sport, this is what you think about doing. Going back to the Y balance test, prior to working with Ascension physicians, I hadn't really seen that in my practice. They were going off of this. They were going off of, your strength measurements and your range of motion measurements. But my first Dr. Peifel patient, he goes, I want a Y balance test. And I was like, well, I better look up what that is and do it right. So certainly just a small example, and that was many years ago, of how our physicians are on the front edge of how we're evaluating our athletes and getting them ready for return to sports safely, and how much they realize that their work's not done when they are like, yep, that ACL, that laxity's perfect, I got it right. They really see the full picture and they really rely on us for the full picture. Other reactive neuromuscular tests, the tuck jump, which is a 10-second, another AMRAP, 10 seconds, tuck jump, as many as possible. And you are looking at qualitative data. You're looking at where their thighs go, what do their knees look like, what do their feet look like. Are they having to pause? Are they that jump roper that it's moving all the time, or are they that jump roper that double hops between every single one? What do they look like? Where do they go? Did they start where I'm standing and end? They start here, and then they're a little bit forward, and then they're a little bit this way. And when you're using like the nice technology that's out there for balance testing, and like I always remember the Wii Fit when it first came out, and it's like you're standing there, and as you fatigue, the circle gets a little larger and it gets a little lopsided, and you're looking at that kind of multi-dimensional picture of where they go and what do they sound like. Is it someone like me sounding like someone like Mike? Is it someone like Mike sounding like someone like me? All of those qualitative things give you an idea of what they really look like from a biomechanical head to toe perspective. Obviously that's a lot to evaluate in a very short time frame. You can certainly videotape, but now you're talking about needing to have some tools available to you in terms of, are you trying to use a tablet? Do you have a video camera? Do you have a tripod? But certainly it's going to give you a more accurate picture on what you can pick up if you can videotape it, slow it down, pull from different directions, rather than having them continue to perform this test, because the other thing you're looking at is what happens over the 10 seconds. Do they look great for the first 3 and then they kind of start to peter out a little bit and then it's a hot mess? Or is it 10 seconds of great jumping thigh high, feet shoulder width apart, neutral foot alignment when they land, no valgus? That's a lot to pick up in 10 seconds. This is another one where, yes, you can compare asymmetries, but because you are still doing the activity on both legs, a lot of it's going to be test retest. When you're looking at quality, speed of jumps, things like that, trying to really compare that they are improving, that you're reducing some of the asymmetries, but also improving some of the overall things like the sound and the distance traveled and things like that. Landing error scoring system, a lot more commonly known as the LESS test. This is a very detailed qualitative evaluation for drop landings based on a very specific height for the drop landing of 30 centimeters. So there's your first barrier. If you don't have the appropriately height box, the research is based off of that. And as we know, especially people recovering from lower extremity injuries, your eccentric control is going to need to be greater at a higher box. So if you're looking for I'm not going to do math on what 30 centimeters is in inches. I will plead American, use the Google Translate for that. But I'm going to assume it's over 12 inches. So now if you're using a 24-inch box, your results are not appropriate. If they fail, their mechanics are going to change. And if you're comparing it to the research, you need to compare it accurately. Certainly you would anticipate for them to break down on a taller box than a shorter box, but nevertheless there are some barriers to using the LESS system. They definitely recommend that you use it with camera system to record from multi-dimensions or multiple people. I know I've worked with some people that have done research about trying to employ the LESS test out to coaches and strength and conditioning coaches to try and do this mass evaluation tool for particularly your jumping athletes, which I would absolutely say are your appropriate testing population. A runner is probably not your target audience for using the LESS test. Certainly there's some utility, but your target audience, if you're looking at basketball players and ACL tears, the LESS is going to be a more appropriate functional assessment of what they do. But the research is mixed about using it clinically in terms of what people are finding. If you do the preventative baseline testing of everybody, there's a research study that followed over 5,000 athletes for greater than 3 years. So you're thinking, I got a pretty good amount of data. This is going to show, okay, if we've identified people at a certain threshold, just like we did with the FMS screen, where you're going, all right, your value is too high. So they're looking for errors, so a higher score is worse. And they're looking at non-contact. Most of this ACL research, as we move on into more of the research based about the testing, is non-contact ACLs. So they watched them. They're figuring, we looked at your jumping and landing mechanics. That's non-contact. This will translate very well. The results did not predict who would suffer an ACL injury based on the LESS. There was not enough statistical power with even all of those ground contacts, those days of practice, that amount of repetition. They tried teasing things out, taking gender out. Well, for sure we'll find it in females. Nope. Found nothing based off of sex. Well, maybe it'll be a more appropriate tool, maybe in like a high school setting where you've got a lot of athletes, not a lot of sports medicine staff. Maybe we can kind of get through this training faster, identify more target audiences compared to, maybe a Division I team where they've got one athletic trainer, one strength coach, and 15 or 20 athletes. Nope, nothing. So at this point, I'm sure you can find research out there that says, oh yeah, we identified people the less at risk for ACL tear, but they tried to really amass a lot of data. And this was the largest study out there, and they did not find evidence to support that the less is necessarily going to target your non-contact ACL risk and then be able to address them. This is where it starts to get fun for me. The first part, going through the protocols, kind of explaining how to use things. I'm sure some of you knew every test I talked about. Some of you may be better versed in it. This is where it gets fun and we start to really talk about why some of these are useful and why we should be using them in our practice. I kind of started out with the best research study first for the topic, and partly for shock and awe factor. So Agresta et al. Looked at healthy runners. They had criteria regarding, you need to be training for a half or full marathon, so they're definitely looking at endurance. Age was not a factor. They ranged from 22 to 54 years old. And their definition of being injury-free meant for at least the last 3 months, you had not had any sort of biomechanical related, musculoskeletal related problem that limited you from performing your training protocol as designed. So there was no restrictions, no modifications, and no days missed related to some sort of complaint that they may have had subjectively. These athletes were not considered elite. So at 3 years of experience, they did the cutoff. And the biggest thing is the average. If we go back to that FMS screen that we talked about, 14 is the cutoff for increased risk of injury. The average is under that. But then when you delve deeper, people talked about, well, yeah, I've had at least one training-related injury in the last 12 months. Some of them reported more. And then they broke it down into what they saw from gender. The squat was about the same, compositely about the same. The squat score individually was compositely about the same. Men did a little better than women, but nothing that put people into the one category, and one means they cannot complete the activity even with modifications. So the females had more twos on the squat. The one that I really want to highlight is the push-up test. 62% of the women scored a 1. They could not complete it. There were no 3s in the entire group. At least half of the men scored it just a 2, and then an additional 40% scored a 3. So that was a huge gap when you looked comparing sexes. And then the straight leg raise test, of course the females did better. I mean, what clinician in this room goes, oh yeah, all my male athletes that I see have great hamstring flexibility? No, doesn't happen ever. So that one wasn't surprising. The squat form wasn't necessarily surprising based off of what we see with valgus and internal femoral rotation in females. The push-up one was rough. Well, they're runners. We don't need to lift upper body. We just do lower body. How many times have you heard that? And I'm not going to hear that from Lauren Jensen, and I'm not going to hear that from anybody in the table, and we're not going to say that as clinicians in this room, but especially in the high school setting and college setting as well. Strength training is overlooked. Upper body is overlooked. My soccer athletes don't think that they need to lift upper body. I'm like, you realize you get contact, right? And I don't want anything bony sticking into anything bony of mine if I'm getting contact. I'm delivering the blow. So this one, unfortunately, kind of reinforced gender stereotypes, but certainly should make us start to think about what we need to be employing in the rehab process. The other thing to mention quickly, and it's a whole other continuing education course that you could talk on, the sling patterns that have come out in research. They all connect. They don't just stop at the hips. They go through the pelvis. They, continue to travel superiorly. So if you're not training that way, we're probably going to see some problems. FMS and Y balance tests. There are multiple tests at different levels. The biggest thing to note is they were run relatively the same way. They found very similar things. Time and time again, you're going to hear me say, females are at an increased risk, Females have worse form on things that require greater trunk stability or transfer of energy from the lower extremity to the upper extremity. It didn't matter if it was Division III or Division I. It didn't matter if it was basketball or volleyball or a variety of sports. They compared everyone, and some of the numbers are pretty substantially staggering. That Division III one, which is the Lair et al. Research article, 17.6 times. If I can drop that as a clinician, even if you drop that in half, you're already making huge strides. I mean, granted, the goal is 0, but we need to be realistic here, and that 17.6 is a really long way to go. The Division I study that was based on basketball players, they found the same stuff regarding shoulder mobility is better in females on the FMS, and the straight leg raise tests are better on the FMS, but the push-up test is worse. Division II study looking at only female athletes, and they looked at primarily your ACL, higher risk ACL athletes, your volleyball, your soccer, and your basketball. And you know that as much as research is supposed to be unbiased, a lot of this stuff is, we're all thinking ACL, we're all thinking non-contact, how can we prevent these high time loss, debilitating injuries? So this one is definitely a little bit more geared towards those, but you can see from these current studies compared to the first one on the running, the results are pretty similar across the board. It's not because you're a jumping athlete, it's not because you're an endurance athlete. They're seeing more sex-related differences and probably training-related differences, and by that I mean strength training or lack thereof. So this Division II study looked at when you hit that threshold, their risk increased 4 times. 69% of the athletes that were at 14 or below sustained lower extremity injuries. When they looked at 13 or below, 81.8% of those athletes in the following season, they did these as baseline testing at preseason. They tried teasing out the shoulder mobility one, and then the correlation became even stronger. When they put that one back in and took the push-up out, then it weakened the study. So again, you're going, oh, push-up, I don't really need to be able to do that. This study especially said our strength of our study went way up when we took out a mobility one, and went way down when you required a lot more stability and global stability throughout the body with weight bearing in a closed kinetic chain position. Shifting gears a little bit away from the lower extremity and looking at a baseball study. So the theory was you're seeing lower extremity activity affected by upper extremity and core strength. Is the reverse true? So they looked, using the Y-balance test, at matched controls. So it was position, it was years of experience, it was limb dominance, it was level of playing. I mean, they really matched these 30 and 30. And the athletes with the UCL injury, it was an active injury. It wasn't reconstructed at this point. It was a fresh injury. Not only is their balance worse in their stance leg, it's also worse in their lead limb in the experimental UCL injury group. Now, they did find there was a little bit of range of motion deficit in the shoulder increase. They said the GERD symptoms in the posterior shoulder laxity was the same, or lack thereof, but there was slightly decreased range of motion by about 5 or 6 degrees in the experimental group. So there was a little bit of limitation there, but to be significantly, deficient in single leg stance in a activity that you're, especially 25 of the 30 were pitchers on each side. So now you're talking about that balance coming downhill, that sort of control, and now you're supposed to do something explosive. Where's your transfer of energy? It comes from your arm. That's why you're injured. As we can kind of make that gap as clinicians, kind of hop that gap. Looking at the STAR balance test, one study on that. Like I said, previously, they focused in on those same 3 directions that the Y balance test did. And again, baseline study, and then looking at injuries that were recorded in a season. Little bit of murky results on this one in terms of detailing, but they compared sexes, they compared composite at reach, and they compared different body positionings. And they for sure said that anything over that 4 centimeter asymmetry in anterior reach affected your injury risk. Females that were reaching less than 94% of their limb length were at a 6-time increased risk. And one of the biggest things to note is that if you have decreased anterior reach, you have decreased ankle dorsiflexion, and that can be linked to a lot of issues with regards to normal range of motion and injury risk. One more upper extremity study, especially for our endurance athletes, is a swimming study for NCAA athletes Division I, directly comparing males to females. And they did this intentionally expecting differences, mostly based off of that information you see right there on the injury risk. Those values for participants in, when you're directly comparing males to females at the same level, for head, neck, back, and shoulder injuries are exponentially greater. So they anticipated the results of this study. And they did see a significant difference between how the males and females did on the upper extremity Y balance test. They did not see any asymmetries with limb dominance or anything like that, just as previous research. I did note at the bottom there, a lot of these lower extremity articles were comparing Y balance and FMS scores to kind of try and look for some sort of global functional movement to compare it to. And I have not found any of that upper extremity in the research. So I just kind of pulled some of the numbers that we need to really be aware of as we head into the next section, which I am going to have to speed up through. When you're looking at limb symmetry indexes and limb symmetry in general, and you're under that 100%, they're looking at increased risk of injury, and then we need to kind of delve into, is 90% enough? So limb symmetry is what we look at when we're looking at ACLs frequently, and we forever have been saying 90% strength, 90% on those single leg hops are considered return to sport ready. 2 research studies I'm going to look at below and quickly highlight make a case for at least 95%. I have no idea. There we go. So when you look at these 2 here, for limb symmetry at 85 and 90, everyone passes. When you calculate it for 95%, we find a lot of variability in the results. So in theory, they're saying we're passing a lot of people. If you look at the all test score, only 40% pass with 95% limb symmetry on all tests. Kind of staggering, especially knowing how many re-tears we're seeing. The second study looked at the limb symmetry scores as we've been doing them in the past. They also put in another criteria where they test the uninjured leg prior to ACL reconstruction and use that limb symmetry as opposed to the post-injury test. Even fewer people were passing with 90%. So based on that, do we need to change our criteria? What about when we see symmetry with the quantitative data, but we see femoral internal rotation, increased knee valgus? We hear that they sound like an elephant and they weigh 95 pounds. What happens when the numbers look good and those are going back to the physician, but qualitatively they're an injury risk waiting to happen, a re-tear waiting to happen? And then to kind of dive back into why we're here, what about the endurance athlete, who they're not symptomatic, and we've looked at tools, and maybe we do find them, because a lot of people's arguments have been, well, they're endurance athletes, that FMS screens, not a lot of reps, you're not going to find it. Well, we do. Research says we do. But if you don't and you're still concerned about it, they're still reporting it, evaluate them in a fatigued state. Just because it's not in the research doesn't mean it won't work. Doesn't mean we aren't going to find what we need to find and help treat our athletes, because at the end of the day, that's what they're feeling, and we've got to find out why. So heading into, I was going to talk about some current research through ESPN, but I'm behind schedule. So there are 2 articles out there. They tie in. Look them up on AAU basketball. Moving on to what we're going to do for these, a lot of this is very similar to what both Erin and Sarah both presented on, but it just gives you a little bit of structure. And this is just one way of addressing the entire issue based off of what you find. And each of these slides will go into it in more detail. People will probably call it different things. Like I said, this is exactly what Sarah and Erin were talking about. You're going to inhibit what's active, your trigger points. This is your manual therapy. And then, like they mentioned, you don't do it in isolation. So now we need to get ourselves back to the new normal, try and create the proper movement pattern. So once you've lengthened the tissues that have been restricted, you activate the ones that are underactive. And then you go from a local approach to a regional approach to a global approach. A simple example is to get rid of the TFL restrictions, the lateral quad restrictions in an IT band symptom situation, lengthen those tissues, then talk about activation of glute med, glute max, those pelvic floor muscles, and then you talk about taking your sideline hip abduction and you start to make it more functional. You put them weight bearing, you make them closed kinetic chain, you start to mimic sport function. Before Crosby yells at me, I'll go through the limited amount of research on true return to sport. There are 3 return to running protocols in the research, 2 based on stress fracture, 1 based on hip arthroscopy. This first one's more current, and they highlighted the Sarah 50% distance for those people that are trying to limit and get back in. And as we've said 4 times already today, with rehab, with strength training, with balance training, with proprioception. This is not in isolation for those people that running is their outlet and running is their outlet. It has a nice little table to kind of give your athlete a weekly plan and discusses increasing time, increasing distance. This study talked about deep water running and anti-gravity treadmill training, which a lot of us don't have access to. But it does kind of outline and give a program, because just like athletes like to document, giving them structure is great too, because otherwise they'll just go. This is the previous research out there. It's a lot less detailed. They do highlight recovery days and gradual increase in distance, then increase in frequency, then increase in things like surface, hills, speed work, pace, those kinds of things. The hip one is incredibly detailed and very beneficial. Obviously, you all have access to the slides. They talk about your little subjective monitoring and give some more concrete details to, again, people that like to run and don't like to quit. Gives them a little bit more quantitatively, this is when you're allowed to progress. They're very specific with their exercises that they make them continue to do, and yes, it's hip focused because of the injury, but if you look at that list, it's a lot of gluteal work, it's a lot of core work, it's a lot of closed kinetic chain, and stuff that we have talked about being very beneficial throughout the day already. They start with like this walking clearance, when you can tolerate that pace for that time, then you can move on, and then they also outline a plyometric program, and then progress that from phase 2 to phase 3, which is what your endurance athletes are really looking for. They have a very nice setup where they create a baseline of how long you can run on a treadmill, how far you can run at what pace, and create a baseline, and then you need to be able to repeat that same baseline 48 hours later, symptom-free. Once you do that, then it gives you your training program, and it gives them a lot of quantitative guidance. Again, the goal is people hate running on treadmills, but it controls their pace, it controls their time, it controls the elevation and things like that. So they recommend starting on there. They show how to progress. They recommend reassessing, because if you're progressing faster and you're progressing well, adjust, and if you're not, vice versa. And then they say once you hit your peak distance and you speak to your patient about what their goal distance is, then you talk about changing other variables and doing so in a calculated manner. There is one returning to swimming. It is based off of a case study in a Division III male athlete with a Bankart repair. They have some criteria to start the protocol, which again are nice and quantitative. And then they focus just like we would with running. We want you to do it right first. Then we want to build how far you go. Then we want you to get conditioned and in shape. And then we start to look at what your individual goals are once that's been met. They also have a subjective guideline like the running, and they have a very detailed protocol that I will not read to you, as you all have access to it. Finishing up now that I flew through that part, as you can see, there were 4 protocols. That's it. I spent a good amount of time looking for research out there, and we've all heard, 1 minute running, 1 minute walking, 2 minutes running, 1 minute walking, but it says who? No one, according to what I found. So there's just not a lot of research out there. There's a lot of Instagram research and Instagram coaches and people with what works for them, which yes, common sense. If what you're doing is flaring everybody up all the time, well, then it doesn't matter if the research validates it or not, don't do it. But right now, there's just not a lot of quantitative studies out there for us, especially as athletic trainers, to really bridge that gap completely. I found some I like a lot better than what I had been using, but there's still definitely work to be done. There were no biking ones. Well, what my athletes do for biking is a lot different than what a triathlete does for biking. And the biggest thing I feel like the research is ignoring is that people do cross-training activities as their sport. And we need to be able to consider that standing up on a bike, locked in, is totally different than riding the recumbent while sipping your Starbucks. And we need to really delve down that road. Time and time again, let's hammer resistance training. And when you're done with your rehab, because you've returned to sport, you're not done. You need to continue to do it. You need to look at especially that core strength. We've been hammering glute med and glute max. We've been doing that since we found it with ACLs. We got to keep moving the chain up higher and really look globally at the model of care that we're giving. Let's think about, we're all here as part of a team today. So Sarah has her athlete. He runs out of insurance money. He's one of my athletes. Or he only gets 20 visits a year. Or he's an engineering student and he can't possibly leave campus for that long because he doesn't have a car and he's taking an Uber and there's 14 other excuses because that's what we have these days, are excuses. Sarah tells me what he's doing. We have the communication to seamlessly transfer. She has done return to sport single leg hopping, or she hasn't, and she shares that data with me. Or we're doing some of these test retest ones and we monitor the progress. And then he's supposed to see Dr. Edwards. I'm like, hey doc, he's just not doing well. We're following these protocols. We have all this information down. It's all communicated and documented, and we were here and then now we're there. And really thinking about who is a part of our team. And then when you get out to the outreach settings, what about your coach? What about your strength and conditioning specialists? Do you have one? How involved are they? If they're doing these global movements in the weight room, are we catching them? If we're working with them, we don't want to isolate them. How do we get them out there in that limited form that is best for the athlete in all senses? And think about what resources you have available or can access. Is there movement specialists available that can really spend one-on-one time? Maybe they do have the money out of pocket and they want to do that, and you've kind of exhausted what you need to do with them as a medical professional. Last thing would be regarding the return to sport screening. We all do it for ACLs, but what about everything else? We just assume that grade 1 ankle sprain, they're strong, they can hop, they can run. But what happens when you get them into a squat 3 months later and you actually see pathological movement patterns that came from the ankle sprain that maybe you didn't catch at the time because it didn't look that serious, but the pain response was there, and with the pain response comes with that neuromuscular compensation pattern. Maybe we need to screen more widely. Maybe we could prevent ACLs if that ankle sprain, we had used some of these tools as well.